يلا بس خلاص التسجيل حيكون عندك انت غالي ها؟
ان شاء الله.
يلا بسم الله الرحمن نبدا خلاص؟
توكل على الله.
يلا بسم الله الرحمن الرحيم. It's a pleasure to meet you again. Hopefully you found my lecture useful and clear. Today, Dr. Omar, head of the department, asked me to discuss with you the MCH, Mother and Child Health Care, which is the very important part or rule of the primary health care. We discuss about vaccination, and because of time limit, I give only to talk about vaccination. We can talk more, but hopefully it's good enough for you at this stage. Today we talk about MCH. MCH means Mother-Child Health. They are very fragile group in the community. The mother during the pregnancy and pre-pregnancy and post-pregnancy, prenatal, neonatal, antenatal, postnatal. And of course, that child, the baby, the fetus, even pre-conception, pre-pregnancy, we have to take care about both of them. They are fragile, and they are the most sensitive indicator of the health system work, the maternity mortality rate and infant mortality rate. Infant means the baby from birth till 1 year, 12 months, good infancy. They are very sensitive indicator because they are at high risk, especially for babies from 1 day to 4 weeks with good neonatal period. They are very sensitive and very difficult even to control the mortality and the morbidity. And of course, the mother, although pregnancy and delivery is a normal physiological process in human being, but the risk factors for her health and her life is increased, of course, with non-pregnant lady. So this is an area which will cover the health and the follow-up and care of the mother before and during pregnancy and post-delivery till at least 6 weeks after delivery. This is a very sensitive period of her life, morbidity-wise and mortality. Then we talk about the child health from birth till 18 years of old. We'll talk about the neonatal period, infancy, preschool, school period, and during the adolescence particularly. Today I'll talk about maternal health particularly. Then if hopefully have time we'll talk about child health, but mainly today we'll talk about school health. The slide, there are a lot of slides I got from many colleagues, particularly Dr. Jamal Burdam, is the Dean of Faculty of Medicine, Gharian, former Dean. Now he's not Dean at this time. And he, I think, still the head of Community Medicine Department. He's a very close friend of mine and nice colleagues. And he had a lot of work in the Ministry of Health as teaching staff in the university. And sometimes he come to do the exam with us in Nusrata and Al-Khums. So I will talk first my sons and daughters, then we'll have the slide, we'll go through it, and you can keep the slide, I think, for your understanding, the slide, a lot of information, and for the exam-wise, I know students always look for exam, cover all the aspects of MCH in this PowerPoint. So for maternity health, I'll talk about the care of mother. We prepare the mother before she gets pregnant. We have special clinic for prenatal, pre-pregnancy stage, when the mother should check up, be ready for the pregnancy, do her hemoglobin, her blood pressure, blood sugar, to be sure that she's ready. And for many people, give folic acid and folate and iron if the hemoglobin less than 12.5 before she get pregnant, to make her healthy as possible before get pregnant, and can do the torch investigation, the antibiotics against rubella, tetanus, herpes, what we call torch, cytomegalovirus. These 5-6 diseases which can affect the mother during pregnancy, we make her ready for that. And of course, if we can give her counseling about the procedure she will go through it, and if there's family history of certain disease, we have to do screening for thalassemia, sickle cell anemia, before she gets pregnant, to be sure that if she has Rh positive, we'll be ready for that. If she is negative and her husband positive and she has a T factor in her blood, we'll be ready for the baby can have some problem. So this preparation for pregnancy, we have to make the mother as healthy as possible before she got pregnant. And when she, and not every mother can do that, and our system, unfortunately, at the time being not as good as before. During the 60s, we have the health visitor midwives, the clinic, the special clinic for the pregnant mother. Once you get pregnant, from the first couple of weeks, we do the pregnancy test, and positive, here we have to start our antenatal care. And in the beginning, for the 28 weeks of 7 months, we have to have visit for her, 1 visit per month. Then after that, 2 visits per month till I think 36 weeks. And at that time, every week, she has to come to the clinic for follow-up. The major thing we do is general examination, including weight and height, and blood pressure, and of course blood test for hemoglobin, and urine for UTI, for urinary tract infection. And if she has parasite, we can have stool test routinely, so to be sure that she is healthy enough to have this exercise to be pregnant. So to visit once monthly in the 7 months, in the first trimester and second trimester. The third trimester, after 28 weeks, we have to have twice per month. Then for last 4 weeks before to reach 40 weeks, we have at least once weekly if there's a need. Plus, she have open door for any emergency and urgent call. I forgot to tell you, during the pre-pregnancy assessment, we have to discuss with her the breastfeeding. We have to prepare the mother about the importance of breastfeeding, to be ready and not be, especially of the primary young ladies who will be pregnant for the first time. We have to give as much information as possible with some booklet, some leaflet, some video if you have, to tell her what's going on about the pregnancy, what's the pregnancy, what's your uterus, how the size of the abdomen, the pain, the colic pain can have sometimes after 16 weeks. All what she will face, we have to prepare her for that. She will not be surprised. But the most important factor, as I mentioned, breastfeeding. Breastfeeding, we have to talk with mother before, and during the antenatal care. Make her about the care of her breast, about how to handle it, how to hold the baby. The nipple, how to care about the nipple, and if you have in the future some inflammations, swelling of the breast, will make her ready from the zero level, before she got pregnant, and during the antenatal care. We keep talking about her to force the breastfeeding idea in her mind, so can believe in it, and whatever the social, the community, the nurses, the doctors in the hospital cannot change her mind. She believes in breastfeeding for her sake, and for her baby's sake. So this is part of the education. We talk with her about exercise, the movement, not gaining weight. Hopefully, when they gain weight during the first visit, she has not suppose she has not allowed to more than 12.5 kilo at the day of the delivery. And the increasing weight during the pregnancy should not increase 12 kilo. Hopefully even less than that, but more than 12.5, that too much for her heart and her diabetes and her blood pressure. So we will weigh her regularly, advise her regularly about the proper diet, has to have good fiber diet because she may have constipation. So should have a lot of brands, vegetable, green vegetable, all high fiber fruits. This has to have her meals. And the morning sickness and the first trimester, we have to make ready for that. She expect to have some sickness, some vomiting, some abdominal pain. This be not very common, but is not uncommon. That happen to many mothers. So we make her, especially the primary, we make her ready for that. So a lot of health education, a lot of friendship relation between the midwife and the doctor and the mother, and the clinic. The hair file should be completely full each time, documented or each visit by numbers, the weight, height, the blood pressure, the hemoglobin, urine test, all the pulse, everything around her health should be recorded in regular basis. And the ultrasound is very important, but at the time being in Libya, there are a lot of abuse of it, and you need to do in each visit and each complaint. And maybe the obstetrician tell us that was not more than 4 times per pregnancy she needed, and regular with the assessment, the size, the age, and the placenta. But the abuse of the system now, that almost over weekly sometimes to ultrasound. Till now, no evidence that the side effect of ultrasound will not affect the mother or the baby. But God knows in the future, maybe we'll find out that many ultrasound without really a need, only because of the demand, this can find out that maybe have problem. But scientifically, till now, no evidence. But financially, the expensive waste of money of the family and the health system. So this is the regular follow-up visit till she could delivery. Of course, we expect that the measure blood pressure is very important because a lot of mothers, not a lot actually, some mothers have high blood pressure due to the end of the pregnancy with eclampsia, preeclampsia, and eclampsia was very, very, very serious problem. They have edema, proteinuria, and high blood pressure, of course. If you have the mother have edema and feet and legs, and blood pressure is high, and urine have proteinuria, this bad sign that we have to take care, and maybe she needs admission to take it. And the second chronic problem is diabetes. Many mothers can have diabetes for the first time during the pregnancy. And many of them, or most of them, after the delivery, the diabetes will not appear. But they have potentially, as pre-diabetic, they have chance to have diabetes again during the pregnancy in next time, or even the usual diabetes type 2. Because they have potentially more prone to have diabetes more than the other ones. So this is the two major chronic problem can have hypertension and diabetes. We have to be careful about it. Ultrasound, one of the advantages can, if any consider allomas in the babies, spina bifida. That's why we give folic acid. They said the folic acid pregnancy and vitamins can reduce the incidence of spina bifida for many babies. So I hope I give you a summary to cover why we need antenatal visit and you can collect it. I can do it again the end in Arabic, just because of my barrier of accent and pronunciation. Maybe I'm a little bit fast. As you know, I am a little, I'm old enough. I'm almost now 70 years. So I think my voice and my attitude is not as good as young people like you. So I have hopefully to give me an excuse for that. The main objective, now I go through the slide to make you relaxed about the slide. The objective of MCH, as written here, reduction of maternity and prenatal and infant and childhood mortality and morbidity. I think we discussed before about mortality and morbidity in the health system lecture, as how it's very important indicators that if the health system work or not, the mortality and morbidity. We are happy that in Libya, we are much better than many other countries. Although maternity mortality is a shame. The pregnancy is a normal process, physiological process for a human being and even for all the creature or all animals. There's a normal things can happen to any lady, and supposed to pass it without any complication. It's a shame. It's a shame if a mother died because of pregnancy, either antenatal delivery or during the delivery or both. That can happen, but it's supposed to be almost zero. Many countries, unfortunately, poor countries like Somalia, Ethiopia, still high. Maybe 200 mother per 100,000 pregnant mother, which is very high. In our country, it's less than 20 per 100,000, but shame still in many teaching hospitals in Libya, from Benghazi, Misrata, Tripoli, Zawiya, still some mothers pass away, died during either pregnancy or the delivery, which really we have to work hard to reduce it. And the one function of the MCH is to reduce the mortality of the pregnant mother. They die because of eclampsia, because maybe diabetes, because maybe for the infection, for bleeding. This is not allowed in a hospital. Even the mother has bleeding, postpartum bleeding, we have to be ready for that, and the blood transfusion is ready and easy, and we can control it. And very rare cases be out, like placenta previa, and supposed to be really diagnosed by the ultrasound early, and we expect that we have an elective cesarean section, so we can save our. For the infant mortality rate, I think we'll talk it later on when we talk about childhood and protect the infancy. It's also shame to have high level of infancy. We reached around 18 per 100,000 child life birth. And this, alhamdulillah, much better than many countries, but still high. Many, like Germany, like Japan, is less than 5% per 100,000, per 1,000 live birth, which that is possible to congenital anomalous hereditary disease, something from the formation of the fetus can not survive. But the other disease can happen from hypothermia, hypoglycemia, infection, completely controlled now in the developed country. But still we have babies, we lost babies because of the infection, of sepsis, by all meaning, and hypoglycemia, hypothermia, respiratory distress syndromes, I think in pediatric you would take in details about it. I don't like to cover that because this will be covered by my colleagues in the pediatric side. The second function of MCH, promotion of reproductive health. Promotion, I think I mentioned in the health system. العربي معناها تعزيز الصحة, how it can improve the health of mother during the pregnancy. We have to, by health education, by good nutrition, by follow up closely, by support her socially, mentally with the community. This again, a promotion of physical and psychological development of the child. This may be an adolescent. This is what I took in a special lecture for that. Antenatal care, as I mentioned to you, I think the care of the women during pregnancy, the primary aim of antenatal care is the achievement at the end of pregnancy, a healthy mother and a healthy baby. Yeah, this is a fantastic goal. If at the end of this process, we have a healthy baby and healthy mother, come back to her normal life, she can go to work again, our housewife, without any problem because of the pregnancy. This is our aim. This care should begin soon after conception and continue throughout the pregnancy. The main objective here to promote, repeat it again, maintain the health of the mother during pregnancy, to detect high-risk cases, as I mentioned, obese mother, hypertension, diabetic mother, all of this anemic mother, UTI, all of these risk factors we have to detect early. Early detection can make a lot of difference. And have to avoid complication, as I mentioned, hypertension, eclampsia, anemia, bleeding. This all should be prevented. We have to reduce maternal and infant mortality and morbidity, as we already discussed, to acquire the mother element of child care, nutrition, personal hygiene, and environment sanitation. To form mother for the need of family planning. There's many countries still believe that family planning is a very important factor, that mother will have more than 4 or 5 children is too much for her health and for her quality of caring of her children. So they discuss a lot about family planning during the antenatal care. We have to get the mother. I discussed with you about health education and what's the sign, bad sign that should be alert when they receive it: headache, anemia, bleeding, burning of maturation, dysuria. This bad sign should be recorded and announced that when it comes to the antenatal care for them in details. So the antenatal care visit, ideally, as I mentioned to you, the mother should attend antenatal care once a month during the first 7 months and 28 weeks, and twice a month during the next month, and once a week, if everything is normal. The first visit as soon as pregnancy is known or starts. Prenatal service before delivery, the first visit should include the following thing. As I mentioned, I think the healthy history, I have to have full history and physical examination and laboratory examination, complete urine analysis for UTI, stool examination, if she has a parasite, she has a bleeding, complete blood count, hemoglobin, and serological test for TORCH, and if blood group RH determined, and any other type of obstetrician and wife expect to need that. Physical examination, as I mentioned to you in my introduction, weight gain, blood pressure, all the physical examination, particularly the blood pressure, is very important for any patient, not just for a pregnant mother. I don't like to think more about it, but as what's called silent killer. In Libya, one of the surveys we have done, is around 44% of Libyan population, and that sample, which represents Libya, around 44% of that sample have or had at that time high blood pressure. And the main painful information that 50% of them, they have no idea that they are hypertensive because they are no symptoms. It's a silent killer. And even the 50% who've been diagnosed in hypertension, they don't follow up in a regular basis the treatment. Some of them use it as a common cold, take tablet only when they have headache or tired. After that, you stop it. And this bad information, bad education. So it's your duty as a doctor, any patient come to you, child, old, lady, gentleman, you should check blood pressure. Is a bad sign that the doctor, if he missed measure blood pressure, it's good opportunity. Iron and folic acid supplement, medication if there is need, immunization against tetanus. The tetanus, Sergeant we discussed before, the mother should have 5 doses before pregnancy. And a long time ago, we give the mother another dose during the first trimester, and in each 10 years after that, she have the ideal from them should that you have 5 doses. But it's good to have booster dose every 10 years, that you be sure that you have no problem with it, especially if the delivery room is not in a good hygiene. But mother would live into hospital in good sterilization, the risk is limited. But the villages, in my age, we usually the children delivered at home with the grandmother support, and they use non-hygiene tools to help the mother for this is incidence of tetanus high. But still, if we can immunize the mother 5 doses of tetanus toxoid before the pregnancy, and every 10 years after that, we have to be sure that the mother is okay. We'll not worry about her. There are some hospitals give 1 dose of tetanus toxoid during pregnancy, but not necessary. Health education, instruction on nutrition, breastfeeding, family planning, self-care, referral service if there's a need for specialists. We need individual tool and group for care and tool, fan and other services meet the need. The center babies and is identify high. Yeah, this slide said that we have to recognize and identify the high risk group as early as possible. This is the main message here. This case comprised the following: becoming pregnant before the age. Who the risk group? Young mother before 18 years. Old mother before after 35 years. This is a grandma Tibara and grand in primary also. After 35, the risk factor was means they are high. Under 18 also high risk factor. And soil structure, here the slide said 140, but the common thing is 150. Before 150, there's a contracted pelvis, and most probably she need cesarean section. Will be difficult to deliver. Of course, if you have anemia, if she has twins, this needs special care. If she has brief stillbirth means the fetus come out not a live birth, it's died, and not abortion, but is a full term sometimes preterm. But unfortunately, something the baby delivered is not live. We could stillbirth. And intrauterine death. Prolonged post-term, if the pregnancy has more than 40 weeks, up to 42 weeks, we go to post-term pregnancy, and baby have a lot of small for death and have a lot of problem. So we have to take care of her. And as I mentioned to you, pregnancy with another disease, diabetes, in some countries with tuberculosis, liver disease, high blood pressure, and of course, if we have history of previous cesarean section, this we have to be more careful about it. Here, I think discuss with you about the health education. We make the mother ready for her and her baby when come out. Give her all the advice, especially if there is a specific problem. Diet, personal hygiene, medication, radiation. Yeah, we have to advise mother not to have any radiation unless they're indicated by specialized professional doctors who really need to have radiation. Otherwise, very high risk for the fetus. I discussed with you, I think, about anemia, nutrition deficiency, toxemia, pregnancy syphilis, the storage syphilis, German measles, RSS, HIV, and hepatitis. Mental health is very important for the pregnant mother. She will pass through a lot of stress. She cannot sleep well, she cannot eat well, a lot of vomiting, she cannot walk, she cannot do her normal life activity. She will have a lot of stress, especially have other children and a lot of duty either at work or at home. She will pass through a lot of mental stress. After delivery, up to 6 weeks, we got postnatal psychosis. Some people could manic. But alhamdulillah, the recovery rate very, very high. But she will pass through bad psychological situation during pregnancy and postnatal. Family planning, this should be started early and discussed with her to advance that with the method which she can confine the hair, loops, tablet, injection. We have to give her all the choices, and he and her husband should choose what's good for them. During the delivery, the operation or normal delivery, they need special care and should be delivered with a tendency of qualified midwife or doctors if there is a need. They are very critical for her, for the mother, and for the baby. I attend maybe hundreds as pediatrician in Libya and in UK, and we work very, very close, especially with high risk delivery. If it's need section, at that time to some operation, if the position of that baby is not as good as for the delivery and normal delivery, I have to, as pediatrician, to be beside the mother at that time. We'll talk about babies when we have a lecture for that. As I told, childbirth is a normal physiological process, but complication may arise. The need for effective antenatal care is indispensable, even if the delivery is going to be normal one. We have to be careful. Rooming in, they keep the baby beside the mother, and we encourage her to breastfeed. We usually, when the baby still with her cord, we put him or her on the chest of the mother and put her in her nipple, her breast, to suck. Even there is no milk at time. You cannot believe how to be the mother very happy. The best moment in her life when her baby crying, then we clean it and put it in her chest and advise her to put her nipple in his mouth or her mouth, and you can see she was before that crying and sweating, and you can see the best smile you can see in your life. She's really happy, the happiness when the mother, her baby in her chest and her arm, and he suck her breast. She come with the tears in her eyes, very happy young lady. So we have good time to advise her for the breastfeeding during that moment. Postnatal care, the care of mother should continue for another 6 weeks to finish postnatal period. At that time, maybe it was postpartum bleeding, maybe infection. If she had hypertension, to be care about it. She was diabetic, we have to take care. And mental health, as I mentioned to you, maybe she can have psychosis or depression. So we have to be careful. And of course, we have to refer a psychiatrist to help us for that. We have to do our best to prevent any complication postnatal period, postpartum infection, sepsis. I think the breastfeeding, I mentioned that, family planning, provide basic health education. It's a good time to give her education for that. Complication of postnatal period, certain complication may arise, sepsis, hemorrhage, UTI, mastitis in her breast. As morbidity was after delivery, infection, hemorrhage, chronic disease, hypertension, diabetes, malnutrition, anemia, all this can easily be prevented by medical care during antenatal care. Mortality, as I mentioned to you, maternal death due to cause related to pregnancy, labor, and postpartum. This is the cause of mortality. This very shame if that can happen, but it can happen either for pregnancy problem or for non-obstetric cause like anemia, hypertension, malignancy, hepatic disease, renal disease can have it. Obstetric cause, I told about infection, postpartum hemorrhage, toxemia, pregnancy, eclampsia, anesthesia, unfortunately, very bad, and embolism can happen. How can we reduce the mortality, maternal mortality, adequate perinatal care, natal, postnatal, we have to be improved with the health service in the urban and rural area. We have to be sure about the rural area, the villages and far places, small cities, towns. We have to be decentralization, as I mentioned yesterday and other previous lecture. Our service should be distributed in an equal way and high quality in all area of the country. We have to have referral system to transfer patients from place to place, from hospital to hospital, primary care to secondary or tertiary care. And if there's an emergency service, we have to be ready. They have ambulance ready to take the mother from her home or clinic to the hospital. The blood bank, intensive care, all the facilities should be ready for the pregnancy process. Training health personnel, we have to train our people to take care of that. Midwives, doctors, nurses, birth attendants in some villages. Some ladies, usual lady, but with 6 weeks training, can help, like our age when a grandmother can help their son's wife to deliver. That should have some training. This birth attendants should train very nicely and support her with the sterilized kits in her hand to use it when she call her at night to help any mother to be delivered. Indicator of the age, mortality rate of the mother, perinatal mortality rate, infant mortality rate, neonatal mortality rate, was very complicated and very difficult to reduce. We have done our best to reduce the infant, but the first 4 weeks of the baby life is the most complicated and difficult to reduce, even when you have a good health system. Post-neonatal mortality is still high, but you can control it. 1 under 5 mortality is still, unfortunately, high in many countries, but alhamdulillah, start to be reduced in our country. I think we finished this lecture about MCH and mainly for maternity. Hopefully, it will be clear. And we can stop now. And the second lecture will talk about school health. Hopefully, you enjoy it.